Welcome to EM Rapid 2024. Today we are going to discuss the topic hemoptysis. In this module we are going to discuss the introduction, the pathophysiology, the etiology, the diagnostic approach, the differential diagnosis and the differentiating features between hemoptysis and hematemesis, and finally the management of massive hemoptysis. So, hemoptysis is defined as the expectoration of blood from the respiratory tract below the level of vocal cords. In 1 to 5% of the cases, it is massive in nature and can be life-threatening. Massive hemoptysis is defined as expectoration of the blood around 100 to 600 ml at a 24-hour period that results in hemodynamic instability, shock or impaired alveolar gas exchange. Massive hemoptysis has a mortality range of around 80%. The cause of death in massive hemoptysis is not hemorrhagic but asphyxiation from inability to oxygenate or ventilate. Coming to the most common causes of massive hemoptysis, they are TB, bronchitis, mycetoma and cancer. TB is the most common cause in India and worldwide. Aspergilloma, bronchiectasis and cancer carries higher hemoptysis related mortality due to recurrent episodes of hemoptysis. Clopidogrel and warfarin should be avoided prior to transbronchial lung biopsies. Coming to the pathophysiology of hemoptysis, in minor hemoptysis, it is due to the injury of the tracheal bronchial arteries due to vigorous coughing or minor bronchial infections. Whereas in the case of massive hemoptysis, it is disruption of the bronchial and pulmonary arteries. Hemoptysis develop from airway, parenchymal or cardiovascular processes. Coming to the differential diagnosis of hemoptysis, it can be classified under several subheadings. In airway diseases and parenchymal diseases, vascular diseases, hematologic and cardiac diseases attributes to hemoptysis. Examples of airway diseases include bronchitis, bronchiectasis, neoplasms, trauma and foreign body. Whereas parenchymal diseases involve TB, which is the most common cause, other infections like pneumonia, lung abscess, fungal infections. In vascular diseases, there is pulmonary embolism, arteriovenous malformation, aortic aneurysm, pulmonary artery hypertension and vasculitis. Hematological diseases like coagulopathy due to cirrhosis or warfarin therapy, disseminated intravascular coagulation, platelet dysfunction and thrombocytopenia can cause hemoptysis. Cardiac diseases like congenital heart disease, especially in children, valvular heart disease and endocarditis can also cause hemoptysis. Finally, miscellaneous causes like cocaine, post-procedure injury, tracheal arterial fistula and SLE can also cause hemoptysis. In hemoptysis, the pathophysiology, there is inflammation, hypoxia and neoplasia that incite proliferation of the bronchial vasculature through secretion of proangiogenic factors such as VEGF and angiopoietin-1. As a result, new vessels are formed and these newly formed vessels are very fragile and it is more prone to rupture into the airways, resulting in hemoptysis. This is the pathophysiology in the case of neoplasms. Then we come to the diagnostic approach. The primary diagnosis of hemoptysis aims at to find the difference between hemoptysis and hematemesis. In hemoptysis, cough precedes hemoptysis, whereas in hematemesis nausea and vomiting proceeds. The secretions are frothy in the case of hemoptysis, whereas it is not frothy in the case of hematemesis. Come to the lab investigations. The pH of the secretions are alkaline in the case of hemoptysis, whereas it is acidic in the case of hematemesis. The secretions are mixed with macrophage and neutrophils in the case of hemoptysis, whereas it is mixed with food particles in the case of hematemesis. Melena is present in hematemesis, whereas it is absent in the case of hemoptysis. The color of the secretion is bright red in the case of hemoptysis, whereas it is dark red in color in the case of hematemesis due to the presence of the pigment hematin. Any previous history of lung diseases point towards hemoptysis, and previous histories of peptic ulcers, CLDs point towards hematemesis. The diagnosis of hemoptysis is made by bronchoscopy, whereas endoscopy aids in the diagnosis of hematemesis. The rate, the volume and appearance of the expectorated blood is important in the diagnosis of hematemesis and differentiate it from hemoptysis. Prior episodes of hemoptysis or parenchymal pulmonary disorders point towards hemoptysis, whereas CLD and other peptic ulcer disease point towards hematemesis. Coming to the signs, focal or adventitious sounds with fever point towards pneumonia or abscess, whereas a new onset murmur with fever, endocarditis causing septic emboli should be kept in mind. The presence of rashes, ecchymosis, petechiae, our differential diagnosis should be any rheumatological or hematological disorders. Signs and symptoms of DVT should be checked to rule out pulmonary embolism. Coming to the ancillary testing, in minor hemoptysis, no specific tests are needed unless the patient is on anticoagulants. Whereas the routine blood investigations we do is CBC, the coagulation test, the tight pancreas matching, RFT, chest X-ray and HRCT. The localization of hemorrhage can expedite bronchoscopic evaluation and guide subsequent interventional procedures in the case of HRCT. Coming to the role of angiography. It is the first line study when the cause of hemoptysis is known. Bronchial artery hemorrhage is suspected when angiography assisted embolization therapy is contemplated. Coming to the role of fiber-optic bronchoscopy. It can be done at bedside with the patient in awake or light sedation. It helps in visualization of more peripheral and upper lobe lesions. The problem is that it has a limited suction capability, whereas rigid bronchoscopy, it needs a general anesthesia or a deep sedation, but it provides superior suction to maintain airway patency. But its limited ability to identify peripheral lesions and does not permit good views on upper lobes. Coming to the critical and emergent diagnosis in patients with hemoptysis. The critical diagnosis include disseminated intravascular coagulation, tracheal innominate arterial fistula, aortobronchial fistula, iatrogenic, that is post-procedure hemoptysis, and pulmonary embolism. The emergent diagnosis include trauma, bronchiectasis, pneumonia, abscess, oral anticoagulant overdose, and endocarditis. Coming to the management of hemoptysis. In the case of mild hemoptysis, if a trace bleeding and viral bronchitis is present, you can discharge the patient to home and you can follow up the patient. Whereas you are not able to find a proper etiology of the hemoptysis, you can go ahead with the routine blood investigations including the CBC, PT-INR, chest X-ray, BNB if indicated, D-dimer, troponin, and other type and screening blood grouping cross-matching. If the chest X-ray is diagnostic, then you can consider oncology, CT surgery, pulmonary consult based on the findings. If the chest X-ray is inconclusive, you can go with CT with contrast. If the chest CT with contrast is making a diagnosis, then you can again consider oncology, CT surgery and pulmonary consult based on the findings. Whereas if CT chest comes as normal, then you have to think about bronchoscopy. In the case of massive hemoptysis, the first and primary thing is to identify whether the patient is hemodynamically stable or not, whether the patient is in hypoxia or not. If the patient is hemodynamically stable, or if the patient is not having any signs of hypoxia, then you can admit the patient and observe and evaluate the causes. If the patient is hemodynamically unstable or the patient has signs of hypoxia, then you can consider bleeding lung down positioning. You can start the patient on IV fluids, fresh frozen plasma, connect the patient to cardiac monitors, pulse oximetry and emergency intubation if needed. If you are suspecting a bronchial artery hemorrhage, then cardiothoracic surgery and pulmonary consult angiogram to be done. Finally, coming to the massive hemoptysis toolkit and the management plan checklist. The intubation tray with range of ET tubes including size of more than or equal to 8.5 mm should be kept. Therapeutic flexible bronchoscope with large working channels and diagnostic and pediatric flexible bronchoscope to aid with bronchial blocker placement, rigid bronchoscope when skills and expertise are available. Bronchial blocker and ice cold saline should also be kept. Large volume of IV to allow rapid volume resuscitation and radiocontrast injections. Patient coagulation parameters including the type and screening should be sent at the earliest. Prompt page to pulmonary or intervention pulmonology for airway stabilization and management, intervention radiology for bronchial artery embolization and thoracic surgery for potential surgical evacuation. The availability of CT scan should be kept. Cryotherapy probe for blood clot extraction. And finally, electrocautery or argon plasma coagulation for ablation of endobronchial lesions. So this is the massive hemoptysis toolkit and the management plan checklist. So summarizing that, for massive hemoptysis, the intubation with larger diameter ET tubes of size more than or equal to 8.5 mm is recommended to enable passage of the therapeutic flexible bronchoscope with large working channels that allows extraction of the blood clot and placement of bronchial blockers. So thus we come to the conclusion. Today we have discussed the definition of hemoptysis, the differentiating features between mild and massive hemoptysis, the approach to massive hemoptysis, the diagnosis of massive hemoptysis, the differential diagnosis of massive hemoptysis, and finally the management of massive hemoptysis. Thank you.